So I request the attention of all the respected faculties and delegates. Kindly allow me a few minutes of yours and let me introduce myself and the faculty members of this session. A very good evening and a warm welcome to one and all. I am Rituparna from Clarinet, the designated session assistant for a seamless experience, and Clarinet is India's most trusted and widely used strategic platform with multiple enriching services exclusively for the doctors. Clarinet is very proud to be a digital partner for this insightful webinar on evolving strategies in reducing Caesarean sections, organized by the Association of Maharashtra Obstetrics and Gynecology Society. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Monica Umbardand ma'am, the Honorable Chairperson of Public Awareness Committee of AMOX, to start the session with her enlightening words. Welcome you, ma'am. So the dais is all yours. Please proceed.
Thank you, Rituparna. I welcome all the esteemed dignitaries, Pardeshi sir and Sujata ma'am. Thank you for giving us a permission to conduct this webinar under the AMOX banner and Public Awareness Committee AMOX. We are filled with gratitude for Suchitra madam and Kiran sir for accepting our invitation as being the guest of honor for the same. And lots of thanks to Shobha ma'am for agreeing to be the speaker of this event and Milicha sir to be the chairperson for this session. Can we have the inauguration slide, please?
Sure, ma'am.
Yes. Let's all begin today's webinar with an insight to Lord Almighty, so that we have Thank you, Rituparna. First, let me introduce the topic for today. It is very close to my heart since the time that I have taken over as a chairperson for AMOX Public Awareness Committee. We have conducted public forums to discuss about the rising rate of cesarean sections and how we as obstetricians could reduce this. So 2 or 3 strategies which came in our mind was first implementation of the Manyata programs at all the government healthcare setups. And that is, I take privilege in telling you, ma'am, that we have launched a pilot project in Sholapur district where we are getting all the PSCs also Manyata approved, ma'am. And the second one was training of our obstetricians in instrumental deliveries so that we reduce the cesarean sections due to the delay in the second stage or because of the obstructed labors, because we are seeing that this is a dying art now and more obstetricians are going in for cesarean section even due to medical legal complications. We are thankful to Pardeshi sir for allowing us to conduct all the programs under this banner, and I am really grateful for to him to accept as an invitation for chief guest for this webinar. Let me take privilege to introduce our AMOX president Pardeshi sir. He has been always there and always a constant guiding force for all youngsters here. He believes in taking everyone together. We welcome you, sir.
Okay. See,
sir, please unmute. Yes, sir.
I wish to add in my biodata, I am disciple of Dr. Suchitra Pandit, and I am proud of that. So, good evening, everybody. Respected Dr. Suchitra Pandit, ma'am, Dr. Kiran Kurtakoti, Dr. Sujata Darvi, and Dr. Melin Shah, Dr. Shobha Gudi, and our ever active AMOC chairpersons, Dr. Rashmi Kar and Dr. Monica Umbardand. First, I wish to congratulate Dr. Monica Umbardand for organizing this important webinar on strategies to reduce cesarean section rate. This is nowadays burning issue. We received a letter from government to reduce LSCS rate. We know our AMOXians are working very hard 24/7 for women's health. I am proud of our AMOX members for reducing maternal mortality rate is 33 per 1 lakh and neonatal mortality rate is 19. Maharashtra is second after Kerala. But still, I think we have some responsibility also to reduce cesarean section rate. Hence, Monica has taken this initiative to aware the public, to aware the doctor for reduction in cesarean section rate. But only because of history of bad obstetric history or conceived after IVF treatment, I think this should not be the reasons for LACS without giving any fair trial to the patient. On other hand, government should exclude doctors from Consumer Protection Act. I think that will also help to reduce cesarean section rate. There are many issues. I think Dr. Kiran Kurtakoti, Dr. Sujata Dalve, and even Dr. Suchitra Pandit also working in many committees. They should take this issue on top. That will also help. Now our elections are coming. I think everybody should ask their candidates, the contestants, whichever the party may be, to work for doctors and to exclude doctors from Consumer Protection Act. With the eminent faculty like Dr. Shobha Gudi, I think she is the right person to guide us on this issue. With chairperson Dr. Milinsha, I think this will be a great event. I again congratulate Dr. Monica. I wish every success to Dr. Rashmi Kahar for her future endeavor in FOXIA as chairperson for Practical Obstetric Committee. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you so much, sir, for your wonderful words of blessing. We welcome Milind Shah, sir, who has just joined. I also take privilege in introducing our guest of honor, Suchitra ma'am, today. She has been a mentor to many of us, including all the senior obstetricians in Maharashtra. Ritu, can we have Madam CV, please?
Monica, don't worry about the CV. Let me talk instead.
Yes, ma'am. Ma'am, the stage is all yours, ma'am.
First of all, I'd like to thank the entire Amox team. Can we stop screen sharing? Then I can talk. I'd like to thank the entire Amox team, including Rajendra Pardeshi, President current, and the President-elect Kiran Kurtakoti, and of course you, Monica, as chairperson of the Public Awareness Committee, and Rashmi Kahar. I think this topic is a burning topic for the last 5 to 10 years. And I would put it in a nutshell that there are, mainly 4 stakeholders which are involved in this. We as obstetricians, we have to also completely change our mentality, and we have to start practicing. And as you very rightly said, Manyata, so with the obstetricians and with your paramedical staff, we are learning, we are changing, and we are learning processes of induction of labor and the different techniques, and Shubha will enlighten on this. The second stakeholder is a patient herself. The patients today have changed. They're reading a lot on Google. They're listening to information given by their friends, by their colleagues, that labor is painful, labor is dangerous, this will happen, these are the complications, and they change their mindset completely, and they want to completely have an easy, without any pain. They just want to go in straight away for a C-section. So changing their mindsets and getting them to get out of the fear of childbirth. The third stakeholders, I would say, is our colleagues, that is the physiotherapists, the people who conduct antenatal classes, the people who are doing all kinds of things. They have to be more motivated. The patient should be able to do lots of exercises, free the pelvic area. Many times, in the past, the women would work at the floor level. Today, most of my girls who come to the OPD have never ever seen an Indian toilet, because they've never traveled to interiors where some places the Indian toilets do exist. Mumbai, 90%, or I think it's the same in the metro cities, everyone has a Western toilet. That itself, they don't know what is squatting. So those things have to completely change. The fourth stakeholder is the government. And as very rightly Dr. Pardeshi put it, the government has to remove that Consumer Protection Act, and doctors are not always responsible for everything that goes wrong. There are things that can happen in the uterus, in the baby, in the fetoplacental unit, where doctors are not always responsible. And the fifth and the most important stakeholder is the public. I think today's public, thanks to movies, to Google, to Ajubajuka information, unnecessary groups of politicians who motivate them, they only want perfection everywhere. They make mistakes, but they don't want the doctors to make any mistakes at all. So they start, particularly in a mob situation, they instigate the mothers, they instigate the patients, and the general verdict outside is today doctors are doing too many C-sections because they want to earn money. So the public awareness, so very rightly, Monica, you have to also educate the public apart from educating all these, the five stakeholders that I mentioned. So all this mind awareness, when it changes, then only our C-section rates will come down. And I'm sure, Shobha is going to highlight, beautifully what are the different methods of induction, how we can improve our monitoring techniques, and most importantly, how we can calm down our patients. I would also like to put one thought over here. You're always against the concept of midwives. Midwives don't take away your practice, but if we have midwives working with us, Sevagram, Pravira, and Fernandez Hospital have shown that with the midwives, the C-section rates are coming down. So, friends, think about it. Let AMOX also take up this initiative. And I'm sure, what Dr. Pardesi is saying. Tomorrow, Dr. Pardesi will be also going in for the Foxy presidential elections. Kiran will be coming as the president of AMOX. So let's all work together and remove that consumer protection threat which is there on the heads of the doctors. And once again, all the best for today's program. And thank you very much, Monica.
Thank you, ma'am. Thank you so much for your words of blessings. I would also like to mention that because we are in the webinar road, we can see only 7 faculties who have joined in. We have more than 105 delegates who have already joined us today and they are listening to us. Thank you. Welcome, Rashmi ma'am, for joining us.
Everybody, a very happy new year, because just 5 days down the line, we'll be into 2024.
We wish you the same, ma'am.
Thank you. Wish you the same, Suchitra. Yeah.
Sujata madam is busy in an emergency. She will join a little late, ma'am. So we can take her comments later. And Kiran sir is in another webinar. He will swipe over. In the meantime, I would like to introduce Dr. Milind Shah sir, who is the chairperson for today's session. Can we have the slide, Ritu? Actually, I don't need the slide to introduce Dr. Milind Shah sir, because he's a father figure to me and he is from Solapur. But he has been on the helm of many institutions, including ISPAT and ISAPAP. He has also been the president of IMA Solapur and the president of Solapur OBGY Society in the past. He has also been the vice president of Foxy in 2011 and honorary treasurer of the FAOPS, that is the Asia Oceania Federation of Perinatal Sciences. He has been on various executive bodies, you name it, and sir is there in the association. But yet he is very humble to approach. We welcome you, sir.
Yeah,
and I
thank
request
you
you
very
to
much.
please introduce Shobha ma'am also.
Yes. Thank you very much, Monica, for all those wonderful words. But in fact, yes, the hard work and the perseverance, those are the words I learned from you. I must congratulate you and the entire AMOX for this wonderful activity because it is a need of the hour. We have realized that cesarean section rate is always and always a challenge, and everyone wants to know what actually happens in the case of labor. Now, the labor is a celebration nowadays. It's never just childbirth, and that's why one need to see that it is properly managed by obstetricians as well as by the patients. Because quite often we have seen the patients have a lot of anxiety. There's always a fear of this Consumer Protection Act and creates a lot of actually problems related to the childbirth, which can be elevated with a lot of efforts. At the same time, we need to utilize the Robson's classification to categorize because the centers they differ from PSC to tertiary care level center, and we'll have to decide accordingly. Huh? Can I have the slide of Dr. Shobha, please?
Yes, sir, sure.
Yeah, introduction. Yeah. Actually, Dr. Shobhagudi doesn't need introduction because everyone knows
Okay.
that she has done a wonderful work actually in the field of family welfare and many other fields. And now she has also joined the ISOPAR platform for actually the activities related to the family planning. So I'm very sure this is going to help a lot actually in creating a lot of awareness about the family planning as well as the managing childbirth. Yeah, can you increase the, actually, put it on, yeah, exactly, yeah. So Dr. Shobhagudi is a professor and HOD at St. Philomena's Hospital, Bengaluru. Postgraduate teacher, examiner, chairperson of this Family Welfare Committee of FOXY, president of Bangalore Bijwai Society in 2019, assessor for the Government of India Project Lakshya, board member of FPAI, peer reviewer for Jogi. She is having many actually other credentials, which can be a long list for to narrate, but she's also very actively involved in the Kasoga. And I have seen that recently Kasoga conference also, her talk was very well taken. She has authorized many books, Foxy Focus, and she has received many awards actually for all this wonderful work she has done. I'm very sure,
Thank you.
Dr. Shobha, you are going to put a good light on this very important aspect, and that is reducing cesarean section rate. Once
Thank
again,
you.
let me thank the MOX President, Dr. Rajendra Singh Pardeshi, President-elect Dr. Kiran, Sujata, and everyone actually for this wonderful opportunity. And Monica, it is really going to be a great success under your committee. So, Dr. Shobha, stage is
Yes.
yours.
Thank you very much. Thank you very much. Shall I share my screen, Monica, now?
Yes.
Actually, yeah.
Yes,
Thank
ma'am.
you so much. And at the outset, my heartfelt gratitude to AMOX President, Dr. Rajendra Singh Pardesi, whom I have known for many years now. He has been a guide for me when I was contesting for chairperson, consequently, twice. And he was the one who encouraged me to not give up and always, persevere. And in addition to, of course, my own mentors from BSOG, Dr. Hema Devakar, Dr. Sheila Mane, Dr. Kamini Rao, my entire BSOG society, Dr. Suchitra Pandit in her year 2014 as the president, really kind of, included me in all her programs, and I really enjoyed working with her. So thank you, ma'am, for being here in particular. Of course, I have known Dr. Milind for so long now, and he's a very good friend of Bangalore Society. Always welcome to BSOG, and thank you so much for introducing me so kindly. My thanks also are due to Dr. Kiran Kurtkoti, the president-elect, to Dr. Sujata Dalvi. I think she's the honorary secretary now, and all other MOX office bearers. But most importantly, I must thank Dr. Monica, because I think the moment I requested that I needed to speak on this subject, she was very prompt, and I think she has done a wonderful job of creating this platform today. Thank you, Monica, so much. To introduce the subject today, at the outset, I must say that whatever I speak today will be merely a drop in the ocean. It will be more a guide towards introspection for all obstetricians to develop more obstetric courage. And this message is particularly for the younger generation, particularly those who are practicing in the private sector, which has become a huge number today because of the burgeoning and blooming of all the corporate sector hospitals. So they have to develop more courage, because that is one of the areas where those are the hospitals where the section rate is very, very high. So cesarean section is actually the most commonly performed obstetric operation worldwide. Some might disagree with me and say that episiotomy is actually commonly performed, but it is regrettable to say that cesarean section is taking over from episiotomy very, very fast. And can you see how simple is episiotomy, and how fraught with danger cesarean section is? So that is the most simplistic way of understanding the danger. Cesarean section rate has been increasing over the past 5 decades. Actually, if you really track the trend, And today we know that it is 30% and more, or in most of the centers across the world, barring the public health sectors mainly, but we do not know whether that incidence of less than 30% in public sector is because of the sheer number of women who deliver there, or in the government hospitals, or actually it is a low cesarean. So it's difficult to say. Now, WHO has set an ideal which is almost impossible to achieve in today's obstetric practice, 10 to 15%. Hopefully, realistically, it will change to 20 to 25%, which we all look forward to. Of course, we all want to keep it that way, but many times in our practice, we find that it inches towards 30%, even if we do not want it to. And then there are many factors contributing to this. And how much is the cesarean section now? So, what is important is to keep asking questions to ourselves to find out what is happening in our day-to-day work. But to set the context for the overall global trending, you can see that, for the past, as I spoke, 30 years, it has shown an increase almost in every country, and highest is in the Latin American countries, followed by the other developed world, and then the Southeastern Asia has a very high rate. Now, governments and clinicians have expressed concern about the rise in the number of cesarean section births and the potential negative consequences for maternal and infant health, and very rightly so. Because what would look like a very low morbidity surgery can have, very potential powerful impact, negative impact on the course of the mother and child. This is a very good study to go through the trends and projections of cesarean section rates, global and regional estimates, published in the BMJ. I think this is a 2021 publication. And they found, when the trending analysis, when they found that worldwide, 21% of women are birthing by cesarean section, which is not very alarming, though it is higher than what is ideal if you consider the entire world. It is some pockets in Africa show a very low rate of 5%, and that is very sure that it is underused, and it must be resulting in some worse outcomes also, because low use is also dangerous. But in Latin American countries, it is more than 40%, definitely indicates an overuse. What is more important is the trend which has happened in certain parts of Asia, increasing in India, and that has shown a more than 30% increase in the rates. So this is the trend which is upsetting for all of us. And if this trend continues, then the projections are by 2030, 28.5%, that is nearly 30% of women worldwide will definitely give birth by cesarean section. And this is not what God wanted for women. God wants all women, as far as possible, to have the natural route of delivery. And, diseases and complications cannot become so high, the pregnancy being a physiological condition, 1/3 of women cannot have a natural birth. So that does not sound logical at all, neither does it sound scientific. So that will result in 38 million cesarean sections annually. And you can see that these are the trends published in that particular article I am talking to you about. And if you can look at the graph C, it is showing Central Asia and Eastern Asia and Southeastern Asia. Everything relates to us and to our neighbors. And you can see the alarming rate of rise of cesarean section in this area. Well, without dwelling too much on this, let me come to the list of countries by number of births. I will request the audience not to Google the cesarean section rates, because cesarean section rates are different. It depends on the number of people residing in that country, and there Nigeria tops the list. But here we top the list. So India is first in this accomplishment, that is in the number of births. And the figure shown here as 23 million in 21 is actually an underestimate, because there are many other demographic efforts which have shown it to be 26 to 27 million. All right, followed by China, and the number of births in China have come down of late. So what will it result in if out of this 26 million births, 8 to 10 million of cesarean sections will happen per year, given the trending? That results in 1 million per month and 33,000 plus per day, and 25 cesarean section every minute. That means every alternate second, there is a cesarean section. And this is a huge burden on the healthcare system because most of them could have delivered, at least 50% of them could have delivered vaginally, resulting in less resources, less expense, and most importantly, less impact on the mother and the neonate. So, what is there in your mind about cesarean section? That is what you should ask yourself. Of course, every obstetrician will claim and will say with conviction that it is a surgical procedure that can effectively prevent maternal and newborn mortality when used for medically indicated reasons. All of us agreed to that. But if there is no indication, then what happens? There is no evidence showing the benefits when it is not indicated. As with any surgery, cesarean sections are associated with short and long-term risks for the woman, for the child, and for her future pregnancies. These risks are higher wherever there is limited access to comprehensive obstetric care. And this should flag us. This should create an alert for us because we have not reached the stage yet where every woman has got comprehensive, state-of-the-art, completely standardized obstetric care because the number of births are also very high for us. So therefore, the presence of indication for cesarean is sacrosanct. That means it's something that we should not deviate from, and we should not perform in the absence of indication, but also we should not deny when it is present. So there is a truism which should be followed in all this. And that truism, if we follow to the last letter, we will be avoiding unindicated cesareans or overuse of cesarean section as a mode of delivery. And that is, every effort should be made to provide cesarean sections to women in need, really in need, rather than striving to achieve a specific rate. So please do not abide by achieving a specific rate. This I am kind of giving it as a forewarning, and all senior leaders in Foxy and elsewhere agree with me that government cannot impose actually rates because it will depend on the characteristics of the obstetric population that one has. Okay, so if there are too many high-risk pregnancies to deal with, you cannot abide by a 15 to 20% cesarean section rate. So what we must strive for is to provide cesarean to women who really needs it, to that mother and that child who really needs it. And automatically the rest will fall in place. So is there an optimal cesarean section rate? I think I have already spoken that we should not look at the rate, but then since there is a lot of hue and cry, let us just think about it for a minute. Optimal cesarean birth rate is the rate which minimizes maternal and neonatal morbidity and mortality, you all agree with me, coupled with maximal maternal satisfaction. Now this factor did not exist earlier. The moment the mother is safe, the baby is safe, nobody bothers to ask the mother, did you have a satisfactory experience? But that is what needs to change today, and the mother should have a good experience, something to remember and cherish. The birthing experience should be that fantastic. Now, this rate is not known. That means the optimal rate is not known and varies with patient population. Rates below 15 to 20 have been associated with increased morbidities. When determining rates, it's useful to calculate the rate in the groups of similar risk using a system such as the Robson's classification. So here comes that magic word Robson's classification, and account for maternal and perinatal outcomes using the classification. So what is the message from this slide? Know your cesarean section rates. Please do not be unaware of what you're doing, because women will feel happy having a child in their arms. The scar on the uterus on the abdomen doesn't bother them. That is the way things are moving forward, because women feel relieved that they didn't have to suffer the pain, but they do not know that some element of imperfection has already settled in their womb, because their reproductive health is already one step down because of the unindicated cesarean section. So therefore, the institution, the hospital, the individual consultant, yourself, myself, all of us should be aware of the cesarean section rate that we are working on, and that is the first step to reducing the cesarean section, globally. So then let me just bring in 1 or 2 minutes of the study that we conducted in the pre-pandemic era, because I assigned modified Robson's criteria as a thesis subject to one of my postgraduates, and she did it I think she submitted the thesis in 2018, and she planned it well. The study setting was our hospital, 1 year. case recruitment, and all pregnant women delivering at our hospital during the study period were included, and study design was descriptive hospital-based cross-sectional study, and the sampling strategy was non-probability sampling. So it was a well statistically supported study. Okay, I will not kind of go into too much detail, only to kind of touch on the fact that Dr. Michael Robson proposed this classification in 2011. He said that CS rates should no longer be thought of as being too high or too low, but rather they are appropriate or not after taking into consideration all the relevant information. And when you classify a woman into Robsons, you get very relevant information. In 2011, WHO recommended this classification, the TGCS, the 10 group classification system, saying that these groups are mutually exclusive. That means if a woman is assigned to one group, she cannot be assigned to another. Her characteristics are so specific for that particular group, and therefore the data that she will generate will belong to that group alone. And totally inclusive. That means all characteristics belonging to that group will be present inside the group. You will not find a similar characteristic in any of the other 9 groups. Now, this is a stratification of women according their obstetric characteristic at the time of admission to the labor room. And 10 groups is based on 5 parameters: the parity, onset of labor, gestational age, presentation, number of fetuses. And this is how it looks. The class 1, nully, term, single cephalic, spontaneous labor, and so on. Class 2 is also similar with induced labor or previous labor, cesarean, pre-labor cesarean section. Class 3 is multi-term, single cephalic, spontaneous labor, excluding previous cesarean section. Class 4 is, induced labor in the multi. Class 5 is previous cesarean, multi. Class 6 is nully with single breech. Class 7 is multi with breech. Class 8 is multiple pregnancy, including cesarean. And class 9 single with different lie, including previous cesarean. And class 10 is preterm, less than 37, including previous cesarean. So then it got modified a little bit. It got modified into induced and cesarean section before labor. So it became even better, because then you could have women who were induced and who had pre-labor cesarean, and you could identify, the problems in each group, and you could find out why, in fact, the cesarean was done, okay, in a better way, and you could kind of develop strategies to reduce that section rate in that particular group. So Robson's criteria, as you see, is essentially a tool for audit for these 10 groups, right? It is not going to in itself reduce the cesarean section in practice. It is only if we audit and we kind of act upon the data which we get in the audit, and then we re-audit to find out what difference it has made, then only we are sure that the Robson's classification has kind of helped us to reduce the cesarean section rate in that particular unit. Are there limitations? Well, this does not allow analysis of cesarean section by demand. So some indications are not mentioned. In fact, indication doesn't play a major role in this. It is only stratification according to obstetric characteristics. There's no indication here. The induction of labor also, the indication and method of induction of labor is not included. So you don't know which method is, likely to lead to cesarean, etc., which is more likely to fail, okay. The degree of prematurity is not included, and the inability of classification to evaluate the relationship between cesarean group rates and the outcome of the maternal and perinatal mortality and morbidity. So the outcome is not so easily comparable in the separate groups because they are so different. But inside the group, you can do a lot of work. Okay, so the contribution rate needs to be looked into, because if you really want to analyze this, then you will be able to find out those factors which can be changed to reduce the primary cesarean section rate. And then in the women with previous cesarean section, adequate counseling and encouraging for VBAC, right? And other strategies like changing the norm for dystocia, the non-reassuring fetal status, training and encouraging obstetrician to perform version when not contraindicate to avoid cesarean for breech. This could reduce the contribution of Robson's group towards the absolute cesarean section rates. Now, all these factors which I have been talking in this slide have more or less been accounted for in the new labor care guideline. So we'll come to that very shortly. So this was the study which was done, as I have spoken. So, okay. I think we'll not dwell on this for too long. I just wanted to tell you the results which we found in this, and we'll come to that. It is easy to implement. This is what we found. Ongoing surveillance, internal as well as external audit, it serves for both purposes. So you have a very honest documentation of your data. And if somebody comes asking, you can immediately show that you have done stratification, and then you have tried to bring down the section rate in each group. And it is a routine tool to report the cesarean delivery trends, because soon we will be asked to submit our trends as well, not just the rates. And the determination of the most important contributor guides the healthcare providers about where to focus, because reducing CS rates is difficult in the presence of so many contributing factors. So this is how it helps us to target areas for intervention. So these are the tables we used for that study, and 1,500 women delivered in that time, and total number of cesareans almost 50%. That was very, very high, because ours is a very major referral center. And then we found something very interesting. We found that the incidence of cesarean before labor was highest in 2B, that is in women with previous cesarean. And, in nulliparous women, cesarean section before labor was high. Okay. And in induced labor also, in nulliparous women, induced also. So our data are looking like it is the previous cesarean, single cephalic, very high cesarean, all nulliparous breech, very high cesarean. Then, in women who are induced also, nulliparous as well as multiparous, the cesarean section was relatively high. So we were able to find out that it is mainly because our inability to give VBAC, and we then started work on that. We started more mechanical induction for those women, and we did find some success. And also, off late, we have started implementing the LCG guideline, the labor care guideline, which is also helping us to reduce the cesarean section, because our waiting period for allowing normal delivery has really improved. Okay, so this was how the study came about in our assessment for vaginal deliveries and cesarean births. You can see that here. Okay, in the first group, it was 56 were cesarean, and after in the second group, it was 257, very high in the induced group. That is how it went. And in the previous section group, it was quite high. In the previous section group, it was quite high. All right, so we shall go on to the advantages of this system. It is simple, it is reproducible, it is a prospective thing. It helps optimizing CS by identifying, analyzing, and focusing interventions on specific group, assesses the effectiveness of interventions targeted at optimizing the use of cesarean section in future. So if a particular method of induction is not working, it is important to sit down and very carefully see what else can be done. Are there any limitations? As we already spoke, indications for both cesarean and induction are not included. Prematurity is not included. The plan of delivery with uterine scar does not become clear. Definitely, you don't expect that here. And direct measurement of repeat cesarean section rate is not possible. Okay, so these are the limitations. Okay, so several experts have recommended that all women who admit to labor group, to the labor room, should be put into one of the categories of Robson's classification. So this is part of the extract of what happened in our study. We found out the main contributing group, the group 5 previous CS term singleton cephalic, largest contribution. For repeat CS Robson group 5 main contributor, the best way to reduce is by preventing the first CS. That is what we realize. Primary CS group 1 and 2 are the main contributors. Therefore, there has to be a very highly improvised case selection for labor induction, and avoiding pre-labor cesarean section will help definitely. as far as possible, allow women to get into labor if there is no risk of labor. Implementation of evidence-based strategy to avoid unnecessary section and to encourage the safe use of VBAC is the need of the hour. So put in more evidence into your practice. Even SOGC has modified the Robson's criteria, and it includes subclassification of women having cesarean section after spontaneous onset, after induction, and before labor. That is how the modified Robson's. It was endorsed by the Canadian Society as well. As Dr. Suchitra said in the very beginning, I think Dr. Pardesi also mentioned that there are more reasons for increased cesarean section rates today. And one of them is older mothers are coming, obese mothers are coming. There is a widespread use of electronic fetal monitoring, and it is poorly understood technology, and I feel, and a lot of false negative interpretations are happening. In the sense, false positive interpretations for fetal distress are happening. And, every time we try to see, it doesn't work because consultants on call are simply not having the courage to wait in the face of even transient decelerations. Induction of labor is also becoming more, so we have to look at properly planning for induction. Epidural anesthesia can work either way, but if we are very strategic about it, epidural anesthesia can help us to bring down the cesarean section rate. Of course, instrumental deliveries have become less. Mid-cavity forceps even I do not use, but outlet vacuum and low cavity forceps should be learned by all our younger generation obstetricians also. It is important to wait till then, because many times before a mother can the fetus can descend to the level of for a safe instrumental delivery, an abdominal delivery happens. So waiting it out so that you can do an instrumental delivery is very important. On demand cesarean section, the muhurtam cesarean section, maybe we must become clever enough to plan the induction whatever in such a way that at least it kind of matches the time that the family wants the delivery. I think that is stretching it too far, but maybe it is possible in low risk situations. At least you will be avoiding those muhurtam cesarean sections, which is such an evil thing to do. I find it a major sin to do. Fear of litigation amongst caregivers is something that might change with the new government strategy which is happening. I think all of us listened to what what Mr. Amit Shah had to say in the Lok Sabha. He has reassured that to some extent doctors will not be, there will be decriminalization of charges against doctors. Let us hope that that comes and that will help the obstetricians as well. About this factor, I think there has been excellent work done by medical legal experts in FOXY for more than 2 decades now, and people should really listen in. Even I find these sessions very, very informative, because we need to practice obstetrics safely, and communication skills have to be really learned. And obstetric triaging is a concept that all of us should be very carefully, develop a skill for obstetric triaging. The message that I wanted to give in this slide is there is a lot which we do not learn during our postgraduate days. I think we have to learn ourselves over the years on how to develop communication skills in a way that we give the correct information. We reduce the fear of the unknown in the minds of women and their families, and also at the same time give them proper care. The communication should be such that they will not turn back on us in the face of any complication, but they will be supportive and say that, okay, we accept, as long as the standard of care is very high, we accept. Now, pre-labor cesarean section, we have to have a lot of thought on this, whether we can avoid any one of them, but these are the conditions where absolutely kind of you cannot avoid cesarean if there is a previous major scar on the uterus, if previous surgeries have been done on the pelvic floor. Okay, if there has been a major, if there is an obvious obstruction or a disparity in size if there is a severe fetal compromise or a hemorrhage, antepartum hemorrhage, a severe medical disease, of course, these are women where you have to perform pre-labor cesarean section. But the cesarean section on demand, the CDMR, is something that you need to be very, critical on yourself when you're providing it, and try to see whether with your communication skills that can be overcome, especially mitigate the fear about the pain by giving good labor analgesia. These are the ones which we thought are modifiable indication. And I have already spoken about the fear of pain. And then there is dystocia, the very vague term of labor dystocia. When nobody knows, what exactly is happening in the labor. And it is supposed to indicate that a woman cannot have normal delivery because she is having dystocia and non-progress of labor. So this is one factor which can be, you can become more skilled in assessing this if you follow the labor care guideline. And then there is fetal distress. Again, you have to be highly objective about assessment of whether the baby is really in distress and have better tools to investigate. For example, simple scalp stimulation test is very good. And if there is a concern that delivery has happened in the presence of fetal hypoxia, try to quickly collect the umbilical cord blood for the fetal pH. That is very important. So it is important to get cord blood pH in such cases to have a medico-legal kind of, a kind of insurance or a kind of safety factor for you also, and to ensure also that the baby, with what kind of hypoxia the baby delivered. Most often, it will show that the baby does not have the severe base deficit and has, okay pH and is not acidotic. Unengaged head is a modifiable indication, especially in multiparous women. You must simply wait it out. Failed induction is a very big subject to tackle. Please be careful when you diagnose a case as failed induction. Please say that, why is it failing? Is it because of the method failure, or it is because some element has surfaced now? For example, a CPD is now more relevant because the baby's head is failing to engage, or a malposition has become evident now. What is it exactly? So failed induction as an indication for cesarean, you should be very careful about saying that there is failed induction. Maybe one should by routine put a protocol for the institution where you can use two methods in tandem. For example, you can use a pharmacological method followed by a mechanical method, or vice versa. So these things can yield a better result than a single method. And then there are always women who are unwilling to continue labor, and that is mainly because of pain. And again, it can be dealt with companionship, with pain relief, with hydration, etc. So the next point is select clinical strategies for reducing cesarean section rate, but the highlight remains that no cesarean birth and rate at your institution, and the trends which are happening. Avoid excessive gestational weight gain. Please warn your women. Optimal use of cervical rapening agent, I spoke about it. Antenatal ECV of non-cephalic, I spoke about it. Give more trial of labor for cephalic, or cephalic, non-cephalic diamniotic twins. I wanted to bring in one factor here. If everything is going well in a monochorionic twin, which is diamniotic also, because many times practitioners are very afraid about giving vaginal birth to monochorionic because they feel that the placenta will not support the labor process because it is single. Please rest assured, if it has not caused any discordance of growth or growth restriction during pregnancy, it will match up to the stress of labor. So even as long as the twin pregnancy is diamniotic, I think it is our duty to give and make it a point to have an ultrasound machine inside the labor room. Recently, we had a monochorionic twin where the second was breech and she was a multigravida. So we have delivered her vaginally, and the second one, breech, we monitored after the first baby delivered, and we found that it was it was transverse initially, it became breech, and she delivered. So intrapartum ultrasound really helps for such cases. Okay, so there is a worldwide feeling today that 39 weeks induction is going to reduce cesarean births. And maybe you can try it out. I have not had personal experience of this, because our policy is to usually wait, because otherwise the induction burden goes very high if we induce everybody. So you can take a call on that depending on but evidence supports induction at 39 weeks as a tool for reducing cesarean section. I'm just telling you the evidence. Slow but persistent progress, okay? Either it is in the latent phase, or it is first stage, or it is second stage. Wait it out as long as the labor care guideline is supporting you. Amnio infusion, okay, I have done it only once or twice in advanced first stage of labor, and a woman should be fairly close to delivery for this to do, preferably a multiparous woman who has meconium in the LICA, thick meconium, and also has fetal heart deceleration. Only meconium, you may not be required to do this invasive procedure because you need to push warm saline into the uterine cavity by the side of the fetal head. And it has shown that the LICA becomes thin, and also it should be warm. The saline should be warm. That is a real effort. And also the decelerations become less, and the woman has a delivery of a non-hypoxic infant, yes, provided the decels stop, okay? And the LICA clears, and the incidence of meconium aspiration also reduces. So it is a useful technique, but requires standardization and readiness in the labor room. As I have told you already, if you are very worried in advanced labor about an abnormal FHR pattern, always try to stimulate the scalp. It is a good alternative to doing the scalp. What is that? The electrocardiographic monitoring with a scalp electrode, which shows that the STT segments are normal in the baby, or even the scalp blood pH. Okay, so that is reassuring, but we do not have that. So scalp stimulation can replace that, and I have found it very useful. Avoidance of delayed pushing. Okay, so there was a lot of thought about protecting the perineum by not allowing the woman to progress till she is in the perineal phase of the second stage of labor. Well, that resulted in non-descent a lot of times, and sometimes women ended up in having second stage cesarean section. It is even happening today. So when the woman gets the urge to push in the second stage of labor, remember that should happen first. Even if the station is +1, she's getting an urge to push. She should be allowed to push, provided she is correctly in the second stage of labor. That means that the pressure on the pelvic floor is there and head is down enough on the pelvic floor to achieve birthing. So the woman should be allowed to push once the second stage is there. After that statutory waiting of about 1 hour or something like that, and especially if she has the wish to push, if she has the sensation to push. Manual rotation, very few people are accomplished in manual rotation, but then from malposition, like occipito-posterior position or so. But I must tell you that what also works is getting very good in the delivery of face to pubes. I recently had a doctor patient, prolonged second stage of labor, and the postgraduates were missing the fact that it was completely an occipito-posterior position, and in no time the anterior fontanelle was under the pubic symphysis, and we had to deliver her with the outlet forceps, so low cavity forceps. So because the vacuum assisted, and then low cavity forceps. So it was not very easy delivery, but then of course we succeeded without any problem. Okay, appropriately selected patients be better and better and better with forceps and vacuum. The sense of accomplishment it gives is far, far higher for the obstetrician than cesarean section. And then also, I have always told my postgraduates that if it is going to be an easy vaginal birth, a midwife can replace you. If it is going to be an easy cesarean section, surgeons make fun of us. They say, what is this surgery? It is just there and you have to give an incision and take it out. Surgeons can easily replace us. But it is in doing cesarean in the correct indication, in difficult cases, in intra-labor cases, or doing difficult vaginal delivery safely, giving a good outcome. That is where the true worth of an obstetrician lies. That is the true obstetrician. And you should read Dr. Ian Donald sir's book, his original book, not the changed version now, to develop what is known as obstetric courage, obstetric intuition, and the willpower to provide vaginal birthing. Collaborative midwifery obstetrician laboring woman model of care. So Suchitra ma'am already gave us the 5 elements of care. Now, The MLC patterns, the midwifery-led care, has become a very loud noise in several sectors in the world, in the obstetric world. I just wanted to say that there is a lot of concern in the mind of Indian obstetricians that there will be a sharing of profession if obstetric, just like Dr. Suchitra said. But I just wanted to say that this is a collaboration and nobody can replace each other. And when it comes to implementing the labor care guideline by WHO, you will need a midwife in place. And believe me, it will result in better training of postgraduates. It will result in better care for the women. It will result in more satisfactory birthing experiences for the mother and the family. And most important of all, you will feel more fulfilled that you have done the right thing. So it is also including the laboring woman in my statement, because LCG, the last component, is involving the woman. Okay, so there are some reasons that women opt for cesarean delivery at maternal request, because they feel scheduled birth has its convenience. There is fear of pain, fear of complications, previous poor labor experiences. That is why respectful maternity care is such a loud phrase today. Concerns about trauma, prolapse, sexual inabilities, concern about risk of emergency cesarean in the middle of labor, or even operative vaginal delivery. And then women want to control situations. They want to control the way that they give birthing. They feel out of control when contractions are happening. And all this is can be done away. Can we help this? Yes, with counseling. But do we have the time? We have to find time. And this is exactly where a midwifery collaboration will help us. So this is a patient statement during a case conference, and I wanted to share this with you. I found it on the net. A woman says, I feel like there's a lot more that can go wrong in a natural birth for the baby than in cesarean section. Okay. So this is what she feels. So in the last part of my talk, in another 5 minutes or so, let me just go through the WHO recommendations, the non-clinical interventions to reduce unnecessary cesarean sections. This is a very huge document, very huge document. So those who are interested must follow this. Okay. And WHO says that cesarean birth rates should be measured correctly, and people should at least have an idea of what is the ideal according to them. I've already spoken about it. Okay. WHO LCG allows better practices to be inculcated and not accounting for patient characteristics and risk factors for maternal perinatal outcomes, because everything should be outcome related, is not useful and potentially harmful. So if a cesarean is done not keeping in mind the outcome, it is going to be potentially harmful. And the critical outcomes of cesarean section, the important outcomes are listed here. Well, time is not permitting, non-clinical factors contributing, the obstetric characteristics of the populations have changed. We have spoken about this. Women have changed a little bit, right? Generational shifts in work, we have spoken about this. Care providers have changed. Physician factors, we have spoken about it. Medical litigation, organizational, economic, social factors. So therefore, there are such documents like, the systematic review of quantitative evidence, 2018, the Cochrane review for non-clinical interventions, right? There were 19 randomized trial on this subject. What are the non-clinical interventions? I'll very, very quickly go through it. Interventions targeted at women. Better education. That's what Dr. Suchitra said. There has to be more noise. Women have to know. There has to be psychological couple-based prevention program, like, they have to be given psychotherapy, nurse-led applied relaxation training program. There has to be psychoeducation for fear of pain. They have to be given more information, okay? And you can use several tools for that. Women should know what is childbirth, that there are workshops available. They should get enough material to read. They should be connected before, even as part of preconceptional counseling or even during pregnancy. Emotional support should be given even during pregnancy. And how many of us talk about labor during the antenatal care? We don't. But if a midwife is present during antenatal care in a separate cubicle, probably she will speak about all that. And then there is one very great need and targeted intervention is a second opinion for cesarean section. Okay, second opinion, especially for scheduled cesarean as well as intrapartum cesarean. So the mandatory second opinion, if you put it in place, maybe the rates will come down. And mandatory second opinion provided by attending physician before cesarean section, who should provide equally or more qualified than attending physician working at the same hospital, selected by obstetric department, agreeing to follow the clinical guideline. So this clinical guideline thing is very important. That is the next intervention. So if I simplify this slide, the second on call system which we have, or a friend whom you can call, this will work for you. Intervention targeted at healthcare professional, again, what else we can do? We should have evidence-based clinical practice guideline for defining indications for cesarean section. So if you simplify it, you apply the modified Robson's criteria, you strategize your obstetric input into the labor room, you create departmental audit or a unit audit, even an individual consultant audit. So if you are having personally some 20 deliveries per month, please use modified Robson's criteria for those 20 deliveries. You will benefit and your patients will benefit and they will appreciate you for your honesty. Intervention targeted at healthcare provision. Again, there's no clear consensus as to what constitutes a clinical indication the value system in place. You should have your value system in place. Go by indications. The fear of blame or recrimination or the financial reward, that should not come in the way. Okay. So health organization, can the system help us? Definitely the system can help us by creating a collaborative midwifery obstetrician staffing model, and that will definitely address the intrapartum cesarean section rates. The intrapartum cesareans at least will come down with this intervention. Okay, the next one, I think the sole purpose, financial strategies. I will skip this because it involves insurance and all that. So implementation is a simple monitoring tool, and what can change for the better is definitely the labor care guideline. We are following labor care guideline in our hospital right now. Again, a postgraduate is doing thesis, our results are good. So this is one of the studies which was done in India, compared 136 to 135 women with this is exactly what we are also doing, the WHO partograph as against the LCG. And you must know that this is the modified partogram WHO, but when we have a labor care guideline, it will have these sections, okay? Information, supportive care, care of baby, care of mother, labor progress, medication and shared decision making. This is how it looks. Okay, so it has got more elements than the WHO. It requires a little bit of training and maybe a workshop module session so that all of us can become good in this. Today will not be the time, but I wanted to introduce the subject. When should it be initiated? Ideally, it should be in active phase of labor after 5 centimeters. This is section 1. This is section 2. And there are the red flags, the alert signs are there. You have to alert and you have to rectify. Companion, no, you have to bring in a companion. Pain relief, no, you have to do. Oral fluids, posture, supine, you have to correct it. Like that. And this is care of the baby, the presence or absence of meconium, deceleration, position, molding, caput, everything is recorded. Care of the woman, her hydration, all her vitals, plus the urine ketones. Okay, urine protein, everything is estimated. The labor progress, this is where the major changes, because in this partogram, as against the WHO, there is active first stage, there is also second stage. There's also second stage. The head descent is indicated with a 0 somewhere here, and this will be the time at 5 centimeters, 6 hours you can wait. At 6 centimeters, you can wait for 5 hours. At 7, you can wait for 3 hours. 8, can you believe that if a woman is at 9 centimeters, you can actually wait for 2 hours safely? Okay. And then the element of intensity of uterine contraction is done away with. It's only the frequency and it is the duration. That is enough to check that the woman is having good labor contractions. Okay. So this is the medication and this is the shared decision making. So here all recording of all assessments and plans, clear explanation, all that is done. So this is how is the shared decision, assess the well-being, record it, check the reference threshold in the alert column, and then plan, talk to the woman and then take her. So everything needs to be documented. Okay, so you have to do it to believe it, because otherwise, only telling you will not work. These are how the magnified parts of the graph will look. Okay, and this is the alert list. So you can see that this the alert. The red column highlights all the alert parameters. Supportive care, what is alert? Fetal parameters, what is alert? Maternal, what is alert? And labor process, what is alert? I have put already at 5 centimeters, more than 6 hours is an alert. At 9 centimeters, more than 2 hours is an alert. So that is how it is going. Okay. Okay, then. So I will not go into this. I think this will not take our time. I will end now. And I will just, this also I have done. I don't think I need to do it. Okay. So what I want to kind of challenge the minds of worthy obstetricians is that we seriously lack data for our population. We seriously lack data. For a country which has 26, 27, 28 million births in a year, we can generate data which can lead the world. So please understand, just like the Prime Minister, is a figurehead for the entire world today, obstetricians of India can achieve a lot. Future research should focus on the following areas. Healthy women seeking care, the study design should be on them, and should be pragmatic RCTs or cluster randomized trials and multi-site study, so that you have a good sample size, and mixed methods. These are all statistical terms. In particular, the guideline development emphasize, that is from the WHO, that future intervention trials should be preceded with formative research to define locally relevant determinants of Caesarean birth. So it should be feasible in the local context. We seriously lack data. That is what I said. So research should focus on interventions, and research should focus on outcomes. Because so far, very few studies are there which focus on outcomes. And outcomes are both short-term and long-term, maternal outcomes and infant outcomes. And that includes incontinence, obstetric fistulae, prolapse, and infant outcomes like breastfeeding, childhood disability. So it's a huge, huge thing to generate quality data. So if not long-term, at least we should have short-term. That is how we cut corners, and we try to convince ourselves that we should do something instead of nothing. So multifaceted interventions tailored to local determinants, barriers, and facilitators of Caesarean section practices. The certainty of evidence for Caesarean section outcome was low to very low for the following interventions, and then further studies are needed. So this is an analysis of what has happened so far. That means educational interventions for women has not been evaluated. Audit and feedback propsins has not still been evaluated. Insurance reforms for equalizing fees, vaginal birth and Caesarean, will it make a difference? Not been evaluated. Collaborative midwifery obstetrician model of care not been evaluated. So these are the areas of research for our young generation, those who wish to do better in obstetrics. These are my references. So in conclusion, there are no global effective interventions to reverse the trend of rising Caesarean section. We can bring out some global effective interventions that will set global context. In low to middle income countries, overuse will drain resources and add avoidable morbidity mortality. For SDG 2030, within the next decade, already we are inside the decade. At first, it used to be remote, this 2030. Today, it is upon us. Comprehensively addressing the Caesarean section, it's a global priority. Global monitoring of Caesarean section should remain a priority to generate awareness and advocate for appropriate evidence-based and respectful care during pregnancy and childbirth. There should be a continuum, and monitoring within country variation, very crucial. And policy makers should implement tools like ROPSINs to evaluate trends on CS and determine ways to reduce rates in particular subgroups. It will help you to strategize your interventions better to reduce section rates. Monitor your hospital yourself and be aware of your Caesarean section rate. So the primary thing is know how much is your own Caesarean section rate. So with that, I end, and I'm really grateful for the time given. I think I have overshot, but I had this much message to give. Guiding principle for WHO intrapartum care model is available on the website. The link to WHO intrapartum care model, you can go there. The link is seen there. You can see that. And thank you so very much for this time. Thank you so much. Thank you. I sign off.
Thank you, ma'am. It was an exhaustive talk, and the need of the hour. Can we have your comments, Milinsha sir? Your concluding remarks, sir? Sir, please unmute yourself.
He is unmuted, but he's not audible.
Monica, till then, can I say something?
Yes, ma'am.
It was an excellent, very, very, I would say, complete talk where it covered everything that could do, what you can do to reduce C-section. My only problem with the Robson's criteria is, where do you classify the high-risk pregnancies, patients with BOH, with patients who've had IVF? So we'll have to have some group over there. And one message I'd like to give everybody is, all IVF pregnancies need not be sectioned. If it's a low risk IVF, you are okay to deliver her normally. It's only in very complicated IVF after many years, failed cycles, very obese patient, comorbidities, those are different situations. And a second, which I'd like to say, Shobha, this, luckily, the place where you're working in, you're able to control situations. In corporate hospitals, what happens is, when there are, you're a consultant, the patient is in the labor ward, the patient is charged by the hour when she is in the labor ward.
Correct.
And a particular time, if you haven't finished your C-section or if you haven't delivered the patient, the OTs are all completely blocked. So that, the corporate sectors have to give, importance to obstetrics.
Yeah, correct.
Okay, doesn't matter. Late hua, kuch bhi laga, they will still give you a theater availability.
Correct.
So people are worried about that. Second thing is, sometimes obstetrician has to go somewhere else. So at that time, if you have a shared care with another colleague, that other colleague can take over. You don't have to say, oh my God, she's 8 centimeters, not yet delivered. Doesn't matter. Let me do a section. Wait, let your colleague take over. It doesn't matter. Shared profit, shared care is so much more better. But a lot of the younger people, Shubha, sad to say that, they want to do everything themselves. I'm not saying young. When I say young, I mean fresh postgraduates. I'm talking about people even in their 40s and 50s. So I think somewhere along the line, let's have this concept of shared care, and very, very nicely you brought out. Let's keep that concept there. Thank you.
Thank you. Thank you, ma'am. That was
Thank you.
really great that you could comment on that. And I'm so grateful. Yeah.
Sir, can we have comments from your side now? Sir, we can't hear you still.
Something is wrong with the connectivity. Maybe
Okay,
the
Monica,
host
I
host
can. Yeah, Monica, I can speak.
Yes,
Sujata
Sujata.
ma'am, thank you
Hello,
for joining
Sujata.
us. And
Hi, Sujata.
please,
Yeah,
yes, ma'am.
sorry. I just wanted to say a few because I couldn't hear your talk right from the beginning. I joined in late when you came to the WHO care. But what I liked about your talk is you have given an incentive to the younger generation, so far as obstetrics is concerned, to do lots more research. And I'm sure that will make them more interesting because nowadays, younger generation, nobody wants to take up obstetrics. Everybody wants to go into fetal medicine and IVF and even, endoscopic surgery. But when it comes to obstetrics, people are a little bit reluctant to take it. So if you give them an incentive, if you tell them what exactly is the thing which is needed, I'm sure people will take up obstetrics because it's a challenging branch. And the way you explained everything to me was quite great and good. And I'm sure everybody should follow the partogram because the moment you follow partogram, automatically everything falls in place. The moment you don't follow the partogram, then the things don't fall in place at all. That is what I just wanted to make a little bit of a comment on that.
Thank you, Sujata. Thank you.
Thank you, ma'am. And that is why we've highlighted the use of Manyata as an accreditation procedure for all the labor wards where the midwives and your staff nurse are being taught how to use the partogram effectively and when to inform the consultants. Secondly, I always remember one of the lines by my senior is doing nothing for a patient in labor is much more helpful than actively inducing her. By the time you finish your OPD, she will deliver uneventfully if you don't intervene.
Correct.
Only
Yeah.
keep on monitoring the
That is
SHS
labor
properly.
care. Yeah, I think.
Yeah, Monica, is it audible now?
Yes, you are audible.
Yes, sir, we can hear you now.
Okay, great. Yeah. So, Shobha, it was really a very good comprehensive talk which covered each and every aspect related to the cesarean section. But two, three important messages were really important. What you said about the second stage. Quite often, people don't understand there is a stage of Thanksgiving that even after full dilatation of the cervix, patient want to relax for some time and then actually the pushing starts. Quite often, the obstetricians start, worried and they start pushing before actually patient gets urged and where exactly the second stage failure indication comes for the cesarean section.
Mm.
The second part, which is very important, of the respectful maternity care. Yes, that is the need of the hour. And that's why today morning, when I delivered this particular oration at Trivandrum, I realized that even the non-OBGYNs, they were immensely happy to understand about this because we need to give a lot of encouragement to the patient when they are in labor. And quite often, that sympathetic approach also helps them a lot to undergo the stress of labor and whatever the stories of old wives they have heard about the labor pains. And suppose all that work together, definitely, yes, we can definitely help reduce and lastly about the partners. Yes, as we introduce the citizen is individualized beyond every normal is also important because we realize that though we used to say about the alert and action, actually alarms of 1 or 2 hours doesn't matter as far as the outcome of the baby or the mother is concerned, which has been proved now in various scientific papers as well. So it was really wonderful, actually, the presentation, and I was really happy to listen to each and every word you spoke about.
Thank
So
you.
thank you very much once again, Monica. And it was a great webinar, great comments, great discussion. I'm very sure all those viewers will be immensely happy to understand, and the rate definitely will go down. About the corporate world, yes, that is the another part of it. But yes, there are also a lot of things which can be improved. Suppose we all are vigilant enough to make some changes in at that particular area as well, and that
Correct.
always help a lot. Thank you very much. Thank you. Thanks a lot. Yeah.
Dr. Milind, I think the corporate heads will soon get intimation from government.
Yes.
Coming, yeah,
Yes.
and that
Correct.
alone will work because after all they depend on their licensing completely on government bodies. So
Yes.
they'll come around and provide more space for obstetricians.
Yes.
They will give better
Absolutely.
support for
Yes.
labor room strategies. Yes,
Very true.
I'm
Very true.
very
Very
sure.
true.
I'm very sure. And obstetricians
Thank
should
you.
have the willpower to go in that direction. Yeah.
Yes. Yes. Absolutely. Thank you. Thank you very much.
Thank you very much.
Thank you, ma'am. Ma'am, and I wanted to also mention that a constant companion in the labor room was my husband's
Exactly.
thesis topic, where Suchitra Madam only was the guide, ma'am.
Exactly. The first alert which comes is in the labor care guideline is when there is no companion. That's a very big flag there, red flag. And immediately, the care provider has to see to it that there is a companion. Ideally, this should be identified during pregnancy in the third trimester, and women should be asked about her choice, whom she wants. And even if it is her husband, the hospital should have kind of enough infrastructure to see that a male attender is present, at least during the first stage. So these things are going to help. If she can choose a female companion, it becomes easier for the system to allow that. So that is something that we work for. So that is there. Yeah.
Thank you, ma'am. Proposing the official vote of thanks, I would like to thank Pardeshi sir and Sujata ma'am for giving us the Amox banner to hold this program.
Yeah.
Shobha ma'am, you have been very kind enough to accept our invitation as a speaker for this session. I also would like to extend my heartfelt gratitude to Milinsha sir, Suchitra madam, Kiran Kurti sir, Rashmi ma'am, for being there with us in the webinar. And Suchitra ma'am, thank you for being there throughout the program and giving your valuable feedbacks. We look forward to more such programs in each and every society so that we can highlight the use of the labor care guide as well as the accreditation of Manyata to ma'am, through Foxy, of course. We wish you a very happy New Year to everyone. Thank you so much. Thank you,
Monica. Thank you. Thanks a lot, Monica. Thank you, Suchitra ma'am. Thank you, Milind. Thanks a lot.
Thank you, Ritu, for being there with the technical support.
Thank you very much, ma'am. It was really a wonderful session. We have received few comments and appreciation from our delegates. And I hope you had a seamless experience, ma'am. So looking forward to host you again very soon.
Are there any questions that we need to answer?
No, ma'am. There are no questions, but only appreciation comments we have received so far. So thank you, ma'am, once again for being with us and extending us this opportunity to host this session. And very new happy new year in advance to all of you. Thank you, ma'am. Goodbye.
Thank you,
Take care.
Monica.
Thank you.
So
you
with
so
all your
much.
permission, dear doctors, we are signing off for today.